我们参加我们ICT 论坛的各位朋友大家早上好或者晚上好。呃今天呢是我们这个 ICT 论坛的第17期也是我们今年在国内今天是新年的初九吧，所以我在此来借用这个机会来向大家拜个年。祝大家新春快乐呀！龙年大吉大利心想事成。也希望大家事业生活皆如意吧。啊，那么我们这个 ICT 论坛呢，是由我们美中抗癌协会中国初级卫生保健基金会肿瘤临床转化专委会、中国医学论坛报和丁香园联合举办的这样一个线上论坛主要是为了促进国际肿瘤诊治的合作和发展。今天呢，我们这个第17期呢，非常荣幸的请到了我们交大州立大学刘志仁教授也是我非常好的非常好的朋友。那么我简单的介绍一下刘教授。我们刘教授呢是03年和我是同期呢到了这个亚特兰大他在作为这个乔治亚州研究联盟的杰出学者加入了这个乔治亚州的州立大学。那么他现在呢是这个学校的杰出的 University Professor。那么他也从这个12年起来他现在也成立了自己的一个这个生物公司嘛，叫 Proda 作为这个 founder 和 CEO。那么我们刘教授呢，他这么20多年呢，就我知道，那么他主要的研究在3个方面，一个就是在早期 P6A 的 helicase，然后后面呢也做这个 pyruvate kinase M2 就 PKM2，它主要关注这个核功能，就是 PKM2 的核的功能。那么他这些工作呢都在 Cell 和 Molecular Cell 发表。那么就我知道呢，我们刘教授是第一个在 Georgia State University 在 Cell 发表文章的教授那么他最近几年呢，做更加关注这个肿瘤的这个转化它这个研究。那么它主要是根据这个 Ranson law 就是设计的这样一个蛋白药物能够 target 这个肿瘤微环境，然后达到治疗肿瘤的一个目的。那么他的确不在这方面做了很多非常有益的工作，发表了像General Experimental Medicine 和那个 Nature Communication 这个不错的非常好的这样文章，也成立了这样一个公司，然后申请到了这个 NIH 这个 Small Business Fund 来支持他们的临床研究。那么在这个蛋白药物的目前在临床也取得了不错的效果。所以我们今天呢，刘教授呢和我们就是来个分享他这方面就是在这个蛋白药物他的这个研究经历吧所以他今天的这样的一个报告的题目就是他给的 Cancer Stroma Y Anti-Integrin AVB3 Targeting Protein Drug 所以我们现在把时间呢交给我们刘教授。
好，看得见吗？
你还没有分享幻灯
还没有分享幻灯，还没有分享幻灯。好，现在分享了吧？
可以，你放到全屏。
好，师兄，谢谢谢谢我们今天这个very good opportunity。然后呢，今天也是新年嘛，那个祝大家龙年愉快龙年万事如意哈，一切顺利。我呢，还是用英文讲，用中文因为很多词讲不来哈，所以呢，我还是用英文来讲，可能讲的稍微随意一点。好， 这个底下是我的这个 disclosure， 因为我们有在美国规定，商业活动都必须要 disclosure。刚才施勇稍微介绍，谢谢施勇的这个非常有意义的介绍哈。我们现在的主要是2个方向，一个是 PKM2， 刚才施勇介绍是 PKM2， 我们主要关注一个 PKM2 在内的核内的 PKM2 的这个功能调节。还有这个包外的 PKM2， 我们特别对这个包外的 PKM2 非常感兴趣。我们目前应该说在这一块领域算是唯一的那么1-2个 lab 做这个包外 PKM2 吧。但今天因为是你这个中美抗癌协会，所以我集中注意力讲我们最近 develop 的一个 protein drug 啊，就是所以我不讲这个 PKM2 这一块就不讲了。So now。This green is the protein we developed. We call it proangel. Okay, so it's developed from host human protein. It's basically CD2, domain 1 of CD2. It's 105 amino acid with mutation 9 amino acid. So now the CD2 is not binding to the original function anymore. So it binds to integrin alpha V beta 3. So the blue is alpha V and yellow is beta 3. So it's not binding to the ligand side. The ligand is red. So because it's not binding to ligand, so what happened was when binds to integrin beta 3 with require of alpha V, it actually activates caspase 8 intracellularly. So it binds outside and activates caspase 8 intracellularly. So caspase 8, you all know, is going to be triggered apoptosis. So the apoptosis will be triggered not by ligand, not by competing or disruption of the ligands. So whether it has ligand or non-ligand, it's no matter. It's always triggered as long as the cell expresses high level of integrin alpha V beta 3 and very effectively. And so then what's unique with integrin alpha V beta 3. So first of all, it's already very, very well-known target for anti-cancer therapy development. It is, for example, it's very hot in the anti-angiogenesis. It's highly expressed in angiogenic endothelial cells, right? So it's also expressed in other cell types. But ironically, this pair of integrin do not express in normal healthy tissue at all. So I just gave an example here. This is human tissue from normal heart, lung, liver, normal breast, and pancreas tissues. You will not see any integrin alpha V beta 3. So it's only pathological related, it's disease related. So that gives very healthy and also, as I just mentioned, it's a very, very old target. Has been explored for a long, long time. Very famous is anti-angiogenesis. It's been targeted at, for example, telangiectasia, right? All those are designed to targeting to compete with integrin ligands, right? So that ligand is the one is RGD mimics. So therefore, the people try to always say they are compete with ligands. So therefore, by antagonist or agonist actions, they could be inhibits the integrin functions. As I just said, it's not activated. It's not expressed in normal healthy cells. However, it expressed in several particular cell type. For example, the angiogenic endothelial cells. I just mentioned that. Also expressed in one of the very predominant cell types called the myofibroblast, which is a fibroblast cell in response to secretion the fibers, collagens or other fibers, right? So that's how it gets to the cancer subject. I guess because this is all the cancer experts, and I don't need to emphasize the cancer is not just cancer cells. It's really cancer cell plus many, many other cell types. So one of the very predominant one is actually cancer-associated fibroblast, right? So fibroblast will secrete very dense fiber in the tumors. And of course, there's also many immune cells, and then like neutrophils, macrophage, and there are endothelial cells, which forms tumor vessels. Very, very ironically and interestingly, angiogenic endothelial cell is high-level integrin alpha V beta 3. Also, very, very interestingly, cancer associated fibroblasts has high level of integrin alpha V beta 3. So that gives us very, very, very good opportunities. We could also use the protein which we developed to targeting cancer-associated fibroblasts and the tumor angiogenic vessel at the same time. So that's how we get here. But that's both of them not new subject at all. Both of them has been very rigorously explored. For example, on the tumor angiogenesis, right? And Avastin is one of the typical examples. Sulfonyl is also another example. Those are already in the clinicals, right? So like I just mentioned, selangitide is also one of the examples. Those of you in China also know the one of the famous drug Indostar is also another example for anti-angiogenesis, right? But all those anti-angiogenesis agents, or we call the drug, there's one common thing is that they're all targeting angiogenic signaling. Okay, they do not directly targeting angiogenic endothelium directly. They are targeting angiogenic signaling. For example, Avastin targeting VEGF, right? For example, sulfonyl is targeting the receptors. But we are showing you the examples. We are targeting endothelial cells, directly kill the angiogenic endothelial cells, right? So secondly, cancer-associated fibroblasts has been quite a hot subject, right? Because people realize tumor has very, very abundant stromas, fibrotic stromas, and people has been so fascinating about how to able to manipulate or targeting cancer fibrotic stroma, and also a lot of approach. For example, FAP has been very, very hard to targeted it. Sonic Hedgehog was create a lot of attentions. PEG PH20 has been so thrilling story, but originally are still not working. And also the FAK inhibitor. Those are all actually targeting cancer fibrotic stroma. Unfortunately, all those approach, all we have up as of today, targeting cancer-associated fibroblasts has not been successful, right? So, but it's such a problem. It needs to be tackled, but still have no successful example yet. So I will show you. I hope I can convince you. We created something that it's successfully simultaneously targeting cancer-associated fibroblasts and tumor angiogenic vessels. So let's focus on the examples. Pancreatic ductal adenocarcinoma, PDSC, pancreatic cancer. Right. Pancreatic cancer has been well known, has very, very, very dense stromas, has very terribly activated the pancreatic stellate cell, which is, by the other thing, is the cancer-associated fibroblast. So you can see the fibroblast is when you activate by the by various methods, you will see integrin alpha V beta 3, particularly beta 3, is very, very strongly activated. And we isolate human, there's a human pancreatic stellate cell, the cancer-associated from patient. We actually see that also the integrin alpha V beta 3 is activated as well. And when we treat this cell by our proangio, you will see the trigger very strong apoptosis activity. It basically kills the cell in 10 hours right away. Basically, also the same with the patient case. So we then take this to testing in the animal models. Of course, pancreatic cancer, there's one big issue with the normal xenograft doesn't mimic the patient tumor. So we use transgenic genetic engineering models, KPC models, the famous KPC models. So we treated by our pharyngeal, and then we were looking for the collagen and looking for activated cancer-associated fibroblasts. And then you will see the collagen was really dramatically decreased. And then and activated the fibroblasts is also sometimes dramatically decreased by in the tumors. In the pancreatic cancer, there's one very unique thing is the vessel is avascular in the KPC models. In the pancreatic cancer, in the patient cases, same thing. The vessel in the tumor is completely collapsed because of the tidal and high pressure of the fibroblast. So therefore, there's no blood can flow in. So you have dense fiber, and the vessel is compressed. So therefore, there's nothing can deliver in. So, but when we treat it by our pharyngeal, you can see the vessel is opened. You see once the vessel, but at the same time, we don't activate angiogenesis. So angiogenesis is not activated, but on the other hand, the vessel is open, so we can deliver the blood in. At the same time, we get rid of the fibers. So the dense fiber is gone, so we can deliver the drug with very, very efficiency. So you see that when we treat by pharyngeal, you see the strong increase in deliver of paclitaxel and strongly increase deliver IgG. But we do not understand this. When we treat with pharyngeal plus gene, we have even more than 15 or 20-fold increase of deliver paclitaxel and IgG. We do not really understand why is that. And that actually also shows when we look in the tumor by blood perfusion, use MRI, follow it, DCE MRI, you can see a stronger perfusing of the blood into the tumors upon the treatment. Another important thing is the cancer-associated fibroblast talking to the cancer cell actually mediates the cancer cell drug resistance. Take gemcitabine as the example, and at the time when we do experiment, gemcitabine is still was a standard care, but not standard care anymore, but was a standard care. So gemcitabine was the DFDC. So when that goes to cancer cell actually activates because of various different mechanisms. It activates the cytidine deaminase, therefore they convert the DFD-CTP to DFDU. The DFDU, after converted DFDU, then actually completely abolished the toxicity of gemcitabine. When we treat because of one of the regulatory signaling to control the CD8, cytidine deaminase, is the several growth factors. And those growth factors are coming from cancer-associated fibroblasts. So when we deplete the cancer-associated fibroblasts, the cytidine deaminase is completely disappear or decreased in cancer cell. Therefore, the cancer cell convert DFDC to DFDU capabilities completely lost it. So therefore, we strongly increase the toxicity of gemcitabines, right? So we will see this. So affected by this, we see the reduced metastasis and decrease de-differentiated tumors. Of course, overall is converted to the survival advantage for these animal models. So you will see the green line is the combination of pharyngeal plus gemcitabine, and the red line is the pharyngeal alone. And the blue line was the gemcitabine, as at the time was still as the standard of care, but not anymore. So you will see the gemcitabine plus pharyngeal provides a stronger survival beneficiary for pancreatic cancer. So overall, in the pancreatic cancer case, we are actually deleted the activated cancer fibroblasts. We actually dramatically decrease fibers or collagen in the cancer. we open the blood vessel, so we decrease cancer hypoxia, we increase the deliver, reduce cancer drug resistance. So another example is the breast cancers, right? So in the breast cancer, the same thing, you see the cancer, the mammary fibroblasts, if you activate by TGF-beta, you see increase of integrin alpha-V and beta-3. Same thing, you take the cancer-associated fibroblasts from patient tumor, you will see that various level of integrin alpha-V beta-3. And correspondingly, if you treat by our proangio, you will see that proangio will kill the fibroblasts which express high level of integrin alpha-V beta-3. Will kill the cancer-associated fibroblasts isolated from the patient, which is high level with integrin alpha-V beta-3 expressions. So therefore, we believe it's going to be very similar effect. I actually just try to cut the story shorter. So we did this 4 different models. So I'm going to use this transgenic genetic engineering model as an example. You will see that tumor nodule completely decreased, both in number and the size. Particularly in the survival, you will see this is the same thing. The green is the proangio plus different chemotherapeutic agent, paclitaxel and gemcitabine. So we will see in the situation of just transgenic models, you will see the increase by combination. You strongly increase the survival of tumor-carried mice. Similarly, if you see the collagen by this red staining, you see that collagen is dramatically decreased. This is take example in the US41 tumor as an example. You will see that smooth muscle actin staining of the cancer-associated fibroblasts is dramatically decreased. And of course, due to that, the blood perfusion, which is reflected by dextran infusion, and also the blood vessel leakage, which is reflected by lectin, are dramatically, the blood vessel leakage is reduced, while perfusion is increased. So that is similar effect as we said in pancreatic cancer, particularly when we look at it, as we just mentioned, we actually found that when we treated with depleted cancer-associated fibroblasts with gemcitabine case in the pancreatic cancer, we actually prevent the cancer cell to convert the DFDC to DFDU. So we wonder whether it's staying that proangio, because it depletes the cancer-associated fibroblasts, has a similar effect. So we also characterize the DFDC and the DFDU and the ratio of DFDC and DFDU. And we will see, yes, this does the same thing. So you will see the proangio treatment will preventing cancer cell convert the DFDC to DFDU. So increase gemcitabine toxicity to the cancer cells. So that, of course, consequentially will increase the blood perfusion, increase the drug delivery. That you can see that by the looking into the paclitaxel delivery. Because we are actually removed anti-angiogenic effect, we removed the leaky angiogenic vessel. So therefore, we also increase the cancer blood perfusions. So you want to see that when we characterize the hypoxia, because you increase blood perfusion, you are supposed to decrease the hypoxia, which actually was increased the cancer therapies efficacy. So yes, we do see a strongly decrease in the tumor hypoxias. Before we want to go to the clinical study in the breast cancer patient, Dr. Emery suggests us to do a wide spectrum and comparison of different chemotherapy drug with prandial in the different models. So that's the way data with 41 transgenic models with all different combination of doxorubicins, paclitaxels, and gemcitabines, and urolubin. That urolubin is one of the newly approved breast cancer treatment drug. The mechanism is targeting microtubules. So with all of them, our conclusion is our prandial plus gemcitabine is the best combination compared to plus paclitaxel, plus doxorubicin, plus urolubin. We believe the prandial plus gemcitabine is the best. That's why we actually moved on with a patient study with prandial plus gemcitabines in the prandials. So in the breast cancer case, we saw the prandial treatment in the pancreatic cancer. We saw the reduction of metastasis. So we are see if the same thing happened in the breast cancer. Yes, we see a stronger decrease in the metastasis. So another example is lung cancer. So lung has high cancer social fibroblasts. Lung cancer also has very high angiogenesis as well. So we take this lung fibroblasts, human lung fibroblasts. So we treat it with by activated by TGF-beta or by co-culture with A59 median. And then we treat it by our prandials. So we see that only activates the lung fibroblasts will be the targeting by our proteins. This is one of the early data with xenograft of A549, and we see a stronger effect on the angiogenesis inhibitions and inhibition of the tumor growth. But very, very dramatically is when we do with transgenic genetic engineering mice, and we treat by our prandial, and you see what happened was particularly the big nodule, tumor nodule, it's almost completely disappeared. You only have a very small nodule left. So the effect on large lung nodule is really, really, really huge. But as I just mentioned, the lung treatment, the treatment in lung is the immunotherapy or checkpoint blockade has become such an important tool now. People, it becomes standard of care with the PD-1, PD-L1 inhibitors. And that's because the lung is very immunogenic organs. So we believe maybe the prandial has very good merit to combine with the immunotherapy and PD-L1. So we did it in combination of prandial plus PD-L1. You see the picture of the lung, and you do not see nodule anymore. You see a clean lung. All these nodules completely gone. You only see the lesions, some lesions or small lesions. And in 11 mice that treated in the combination group, only one mice died, and that maintained for 350 days. And our treatment is stopped, and tumor did not come back until more than 350 days. And when we look at the tumor's immune cells, and you see a dramatically decrease in Treg cells. You see a dramatically increase of CD8 T cells, and you see a decrease of MDSC cells. And also, you see a very big change of macrophage polarity M1 to M2. You see treatment favor the more M1, favor less M2. So the overall is very much favor the immunotherapies. Okay, so that's how we believe, because immunotherapy is wonderful. It's a very good tool. However, they are in the lung case, not only one, in every tumor case, immunotherapy, the response rate is always not that high, 30%. The highest, 30-some percentage, and some patients do not respond. Even in the lung cancer case, even some patients responded, but they are coming back. one of the biggest issue was the microenvironment. The immunosuppressive environment, cancer-associated fibroblasts, and the angiogenesis play their most important role in the immunosuppress effect. So we believe we are actually stands a good chance with a combination of the immunotherapy. We tested another one with this breast cancer model, 41 models. And then we see the same effect. We see, okay, combination with PD-L1, we see a very, very strong enhancement when we actually combine with immunotherapies. So that's this future should be in the combination with immunotherapies. This is in the breast cancer. You will see 41 is decreased, Treg cells decrease, and CD8 T cells increase. So all this is a very, very exciting. So fortunately, we were able to move this into clinical study. With both with cancer, pancreatic cancer. The first phase 1A is studied in the NCI and NH Clinical Center, and now phase 1B2 was in the for pancreatic cancer is in the UAB, and the breast cancer is in the Emirates. So in the phase 1A in the NCI study, basically our strategy is to first, dose escalation. So far, we have been dosing 33 patients for now. All right. So in the phase 1A study, we completed it. So the dose escalation has been completed. So we are the patient tolerates very well. We are dosing for 3 weeks. Then we are measuring the toxicity as the patient passes that. Then we go through every 6 weeks to restage the patient's tumors. If the patient has a stable disease, then we treatment continue until we see that progression tumors. So in the NCI study, so that's a single agent dose escalation study. So we are treating with refracto. The patient has been resistant to two separate standard care treatment already been progressed through the 2 standard care treatment. So up to that, we have 18 weekly dose patient. One patient has a stable disease for 37 weeks. Okay, and this patient has completely tumor regression, so it's a complete response, and CA199 is completely undetectable. And actually, the patient, because they have some other issue, they need to do surgery. So therefore, they actually, after surgery, based on protocol, we cannot continue. That's why they're off the treatment. But after that, the progressed disease and patient died in 11 months after that. We also have one patient had a stable disease for 18 weeks. And this patient has metastasis in both in the lung and in liver. And the metastasis site, the metastasis nodules completely disappeared. But 18-week stable disease is because the primary tumors started progression. So we actually stopped the treatment after 18 weeks. We have 2 patients had stable disease for 14 weeks, and we have 1 more patient stable disease for 9 weeks, and 1 for 7 weeks, 8 weeks. The phase 1B pancreatic cancer also just started in UAB. We dosed 3 patients now. First patient assessment of the tumor now, we got a complete regression. We're so excited about that. And this is a newly diagnosed patient with naive. So the other 2 have not been assessed yet. But this first assessment, we had a completely response. For now, with these results, we are really excited with it. For sure, we see anti-cancer activity, right? So I will skip this because we had a favorable PK, and it encouraged the PKs a weekly dose used to be. First 2 dose level was first 3 dose level we will try is just using once every 2 weeks. Then this is 5 patient, the PK property in this once 2 week dosing, and we found the 12 levels too low. When we get to 7 days, 8 days, the drug level is pretty much dropped to 0. So therefore, we are changed to 1 weekly dose. And now we actually see the trough level of a drug is getting to 300 to 400 nanogram per ml, which is above the minimal bioactivity levels. So I will take just 1-2 minutes talk about it's not only for the cancer treatment. So that's clinical liver disease, NASH, or alcoholic hepatitis. Right. So one of the unique parts in the alcoholic liver is the same time activation of hepatic stellate cell, which produce the fiber, and also the mess up the sinusoid cells. The sinusoid endothelial cell become angiogenic endothelial cells in the liver. So therefore, the driving of the disease in both NASH and alcoholic hepatitis is because of the interconnected activation of stellate cell and capillarization of sinusoid endothelial cells. So we are actually, remember, we are targeting integrin alpha V beta 3 and deleted the alpha V beta 3 high level cells. So in the liver, now the disease-driven sinusoid hepatic stellate cell and capillarized liver sinusoid endothelial cell all has high level of integrin alpha V beta 3. So therefore, we are one stone. We actually kills 2 birds in the liver cells. So that's one example with this high fat induced NASH models. And you will see we are actually diminished the fibers, the collagens in this liver. We are actually also, because one of the NASH liver characteristic was a lot of fat, so accumulated in the liver, so that creates a lot of fat bubbles. But when we actually treated by our angel, we actually eliminates all those fat bubble. We do not understand why is that. And they actually not only this, we are seeing the liver improve the glucose tolerance. Reduce the glucose level and improve the glucose level tolerance as well. Our hypothesis, our belief is because we are normalize or regenerated the tissue, liver tissues. Okay, so why we regenerate it? Because sinusoid in the normal sinusoid liver is a driving force for liver regenerations. While in the NASH and alcoholic hepatitis, because of the insult from the lipid toxicity and the alcohol, that triggers the high immunotoxins, inflammation. Those inflammation started killing those hepatocyte cells. When we actually treated by our proangel, we renormalize the sinusoid. We get rid of the activated hepatic stellate cell. So therefore, we remove the disease-driving cell. At the same time, because we normalize the sinusoid, reverse the sinusoid remodeling, so therefore we're actually driving the liver regenerations. So the regenerated liver would actually improve the metabolism functions. So that's why we actually see the decrease of a fat accumulation in the liver. We actually see the improve of the glucose tolerance will bring down the glucose levels. And this is one of the typical features here is the sinusoids, right? Sinusoid, when we get to the chronic liver disease, you lost this so-called the holes, a lot of holes, okay? So infection holds when we had a disease, but when we treat bioporangial, you will see that we regain the holes of this sinusoid endothelial cells. And this whole number, because of this hole, so we improve the blood flow from the central vein to the portal veins. And you will see the blood flow when we measure the blood flow by the solid ultrasound images. So you will see the normal with disease status and treated by porangial, you will see the blood actually flow regain normal blood flows. So we believe we stand very good, unique property for treatment, also treatment the chronic liver disease as well. So that's pretty much I was talking about it now. We are actually finished our clinical study. Our treatment for phase 1/2 breast cancer study in Emery was just started. We just recruited one patient and without assessment of disease yet. So we are actually currently complete the phase 1A in the NCI, and we basically found a good the patient tolerates very well. We had good PK properties. We are very excited. We see this primary anti-cancer activities. And so now we are moving on full scales into phase 1/2 study, and to really find the anti-cancer efficacies in both breast cancer, pancreatic cancer. We also, because we have such good effectiveness in the lung cancer, so we are also looking for to study in the lung cancer case. This is old pictures. My lab used to be in the Grady Hospital. This is in downtown Atlanta. But now we're moving into the different buildings. So, but this is an old lab. Was my lab with Jenny's lab together. With two labs in the pictures. I guess I will just, of course, thank. There's all the people. I don't want to go. We don't need to go one by one. I don't want to go one by one. Of course, we need to thank you. The money fund, all the clinical studies also they are supported by NCI, and thank you for your time for listening. And it's in this New Year's time come to listen to my story. This is very grateful, and I'm happy to answer all the questions, any question you have.
OK，非常感谢我们刘教授的分享。说我们刘教授过去10多年来，就从这个药物的合理设计，然后到临床前研究，然后又找钱，又到了目前的这个临床研究，而且看来有初步效果不错。所以congratulations for your success. By now, your achievement.
Thank you.
All easy. 而且你这个 picture 也让我想起来，我若干年前到你们这个实验室，到你们这楼里边。
我们还有一篇 paper together, right? Remember?
Yeah.
P60, right?
Yeah. 我们现在还有点时间，今天我们进入到直播间的人也比较多，看看大家有没有什么问题，或者线上的朋友有没有什么问题我们还有一点时间可以大家进行讨论。
我讲的快了一点这是这个。
It's okay. Yeah. I think it should be a very interesting topic. 你讲的这个，我先问一下吧，就说你这个就说在体外，它可能就讲 quickly 可以 trigger 这个 apoptosis，就是它这个它的一个主要的机理，因为它这个好像很快，就像这个 trigger this 这个 ligand receptor 这个 ligation 以后很 quickly trigger apoptosis，你说10个小时、几个小时，我看
对，十个小时，
就是你们
十个小时，
现在
十个小时
有
不到。
一个mechanism，就是说大概
对，这个是所以它这个是因为这个那很有意思，这个 mechanism 也是新的。嗯，它这个一般 caspase-8 它是 recruited 到 death domain，right？我们这个textbook 都是这样学的，caspase-8 pro caspase-8 recruiting 到 death domain，然后 death domain 我 activate caspase cleavage caspase-8。但对我们这个 protein binding 到这个 integrin beta 3以后，它这个 procaspase-8 就 recruiting 到这个 beta 3的这个 intracellular domain。怎么 recruiting 我们不知道，但是 recruiting 以后我们就发现 caspase-8 它就 cleave 了。但是也有几篇 paper 都说了，你只要把 procaspase 放到一起，它们就会互相 cleave。所以它根本不需要death domain 是什么东西，你只要把 procaspase 放到一起，这个我不记得是哪几优的，他们就会 cleave each other。所以我估计就是这个我们 somehow binding 的这个 beta 3 extracellular domain 以后 intracellular domain somehow changed that some site is exposed there and that site will recruit in procaspase-8。然后那个我们 data 是知道它一定是 cleave 的，有 procaspase-8 在这个 intracellular domain，它可 activate cleave 了是的，但怎么去 recruiting 在哪个 site 我们不知道。
那有没有可能它这个，因为它都是膜蛋白嘛，这个作用以后呢，它 somehow 能够 trigger 这个 cluster of 这个像 death receptor 啊，就是然后这个 quickly activate
这个我们不知道，我们不能排除，但是我们可以肯定它到了这个 integrin beta 3上面了，这个我们可以肯定。但是你就是刚才说的
key death receptor knock out，
对，我们不知道，因为我们还真没有去看过 death receptor death domain 有没有那个 forming， 没去看过。但是我们可以肯定的是，它到了这个 integrin beta 3 intracellular domain。
就说你这个有没有in vivo 的 evidence，就是它引起这个 apoptosis？
这个in vivo 的 evidence 有啊。我们在这个老鼠 tumor 上面，alpha v 那个我们就是你看啊，我这个有个 slide 在这里，但我不知道你这是不是能叫它 in vivo evidence 哈，就是这个我们 stand 这个cleave the caspase-3。然后 overlap with 这个alpha smooth muscle actin positive， 就你就看到它这个most overlap standing 是在这个alpha smooth muscle positive cells。
那这主要是这个细胞死亡，主要是这个 fibroblast 还是什么？也包括
fibroblast， 主要是 fibroblast。
它对上皮细胞好像并
没有影响，
对，因为可以好像那个反而是它那个血管扩张。
对，血管扩张是因为它那个减轻了那个，因为在这个那个 PDAC 那个里面，它那个 fiber 的那个压力挺大的，他就是说把那个压力你把 fiber 拿掉以后，它那个压力就没有了，没有压力以后的血管就扩张了。但是呢，通常这种扩张都会伴随着那个血管的疯长，因为我们是因为有抗新生血管的作用，所以它的血管也就不长。那个 Hedgehog inhibitor 它那个为什么 fail 的？其中一个原因是因为它拿掉这个一部分 fiber 以后啊，它那个没有这个压力了，它那个血管就疯长了， angiogenesis very very active， 然后 tumor 变得 more aggressive。
对，因为你讲的这个故事让我想起我在出国前30多年前，我们请了个日本的教授，当时他讲我当时我为什么记得很清楚，因为当时我做英语翻译嘛，然后他们就讲的，实际上他们就是一个原理，和你们这个很类似，他就是通过。它不是说抗血管，它实际上就是通过这个促进血管的扩张，然后能够促进这个 drug 能够到这个肿瘤里边去，然后杀死肿瘤啊。所以我记得非常清楚。实际上呢，就这也是我有时候想，就是说，实际上呢，有时候在临床上他们用 anti-angiogenesis 也好。还是combine， 所以有时候我觉得不 make sense。有时候我想就是一送食的，让血管一个扩张，然后让这样的话这个药物才能过去，就像你把那个兵力才能输送过去。你要是把这个血管都给它干掉了，那个药物就有时候就很难到达这个深层的这个肿瘤的深部去啊。
对，对。
看看其他的人还有没有问题啊？
哎，我提个问题啊，讲得非常好啊。
哎呦，谢谢。
我有个问题，就是说你这个breast cancer 就是乳腺癌的 model 是用的是哪个 stage？ 因为那个small muscle acting positive cell 不光是fibroblast， 还有那个 myoepithelial cell 也是 positive。
对。
你这个是哪一个？
这个你看的这个是这个在这个它这个 ductal 的周围是就是这个
small muscle layer 对。
但是呢，你在这个因为 small muscle cell 一定都在这个 ductal 和血管周围，可是你要是在这个 global 的那个 area， 它就应该没有，它应该都是那个。但是我们这个 model 这是其中之一个 model 它是它这个 transgenic 是 express 这个 uncle gene， 出名字了，这是非常 common 的 model 是这个然后呢但我们一共是刚才讲的是4个 model， 还有 41， 刚才就是这个一个是 41， 一个是这个 transgenic， 还有一个是 ND231， 还有一个是 PDX， 所以是我们有4个 model 都用过了，但这个结果是你看它这个结果是 41和这个 transgenic， 像这种collagen 和small muscle actin， 它是不在这个血管周围，是你刚才讲的那个small muscle cell， 它是在血管周围的，或者在 ductal 周围的。
对好的，所以这个可能都是 fibroblast。
对，这种都是那个 activated fibroblast， 它就是 globally 它是如果是在这个周围的，我们就把它就不算不计算这里。
另外我还有个问题啊，不是那个就是肺也有纤维化，这个照道理也可以用到那个肺的纤维化的治疗是吧
？In principle, yes， 我们还真从来没有去试过，但是我们不是做了肺癌吗？这个肺癌它的这个肺癌它本身纤维化也是很重的。你看这里这个它的这个我们的这个 CS resistant 和这个 alpha small muscle actin， 所以它这个肺我们没有去专门去做过肺纤维化的 model， 但在这个肺癌的 model 里面，我们看到这个collagen 和这个 alpha small muscle actin 是 decrease。
这个结果也很好，因为这个也可以治疗那个肺的纤维化，这也是一个很大的问题啊。
我不知道，我们没试过，但是 in principle 也是。但是因为肺癌里面，相信我应该知道的更详细是，肺癌的那个纤维化本身就很重而且肺癌纤维化对肺癌的治疗是一个很头痛的问题。
是，对，
所以如果我们说这个就是 overcome 这个也可以也是等于说 overcome 这个问题。所以为什么我们觉得我们应该还是要做肺癌的这个 clinical study？缺钱呢，现在是没钱呢，钱不够啊。
多合作，多合作。
对。
谢谢，真的这个结果非常令人兴奋。
我们是非常 exciting， 非常 exciting。等于是你看这个就是这个胰腺癌的治疗，你看这 clinical study， 它400-500个病人都看不到一个 complete response， 基本上都很难的看到一个 complete response。现在用的这2种 standard care， 我们现在32个病人就是已经看到，就是因为 single agent， 我们已经看到2个 complete response。
哇，
就是
这是奇迹，这真的是龙年大吉，这对病人来讲真的是福音。
我们非常 excited， 非常 excited， 是，因为在一个单药我们就看到一个 complete response， 另外一个刚才这个联用，这还是第一个病人，我们 assess 的第一个病人，因为这是因为我们是6周以后才 access。就已经是看到一个 complete response，complete regression 的 tumor disappeared cannot be detected。
而且这种 protein drug 应该很少的那个 side effect 是吧？副作用应该很小，
安全性挺好，
对，应该不会产生就没有那个 antigenicity 吧？应该不会。导致
我们还没有去测，但这是 FDA 需要的，我们要测的 ADA 对，anti-drug antibody 要测的，但是这个已经不重要了，因为它如果是有 efficacy 的话但是 FDA 还是会要这个 data， 所以我们还是要测的。
好的，
对
，just out of curiosity， 就好奇。但是他那个，你不是已经在动物实验有几百天了？如果还有好的效果的话，可能那个 antibody 就像你说的即使产生一点点，也不会影响它的作用。
它只要不是这种 strong acute， 但我们至少没有看到这个，没有看到病人有急性免疫反应，没有看到这个。
这个也是很好的结果。
对。
谢谢。
路易斯，这种蛋白药物，它将来这个生产的，它的这个 cost 和这个抗体的药物相比，是不是
高多了？比抗体不见得贵。我们上回算了一下，因为抗体它都是用这个 mammalian 系统。它的产率跟我们差不多，也是1000升能有200克左右，差不多，产率也差不多，但是它的那个发酵那些，它的那个 culture media 都要比这个贵，所以最终下来可能差不多，应该是这个 cost 成本应该差不多。
好的，不知道如果其他人没有问题，我看看好像也没有什么问题了。我看看直播间有个问题。卡波他滨影响血管吗？我不知道卡波特滨啥东西。
卡波特滨就是那个就是他是说这个卡波特滨是什么？卡波特滨是金沙的滨吗？就健杂呀，国内叫健杂。国内叫健泽。卡波他滨是不用在这个卡波他滨什么中英文怎么翻呢？我还真不知道。
卡比他滨影响血管吗？ I don't know English. Please.
我真不知道卡波他宾，不知道，还真不知道。英文叫什么啊？我们
没关系了，因为这个时间嘛也没有什么问题了。因为我们这个大家通常真的，我们做科研不容易，实际上我们这个科研成果的转化更加不容易所以我们今天我们这个非常感谢刘教授的这样一个精彩的分享，真是从这个药物的合理设计到临床前研究，然后到然后又要自己搞公司，自己弄钱，然后自己做 clinical trial 所以给我们这个做好多教授在实验室工作的确实是树立一个很好的榜样非常感谢。如果我们在座的听众在座的有对我们这个刘教授的这个东西感兴趣，如果希望能够合作或者投资的话，也可以和我们这个刘教授联系。
欢迎。
另外呢，另外呢，就是我最后呢，我可能要做一点这个广告宣传，因为这个月呢，正好是我们 AACR 下届的 President 的一个选举的一个时期。我们其中的一个后任总统President 是我们杰出的华裔教授，就是李连素那么他作为2个的 President 候选人之一希望我们这个是 AACR member 的话能够如果你还没有投票的话，希望把你这个宝贵的一票能够投给我们杰出的这个 Dr. Su 这样我就希望我们也我们这龙年呢，希望有一个我们的华人的 AACR President 所以我们今天的直播就到这里谢谢大家。
好，那谢谢大家过年。